Sure thing. All right, so my name's Alastair Dunne. I'm a stage 2 GP trainee in my last 9 months of training now. I am also on the NZMA Doctors in Training Council. I'm currently the only general practice representative on that group, and also sit on the trainee chapter executive of the GP college as well, so sort of a dual role there. So you go from a hospital-based setting where ultimately you've got to assume that everyone's unwell till proven well, to working with a population that's primarily actually healthy and well and has probably not come to see you because they're acutely unwell. And it's quite a change in thinking. If you don't make that adjustment, you find yourself ordering unnecessary tests, prescribing unnecessary treatments, making unnecessary referrals, purely on the fact that you haven't identified that the patient is actually well. Isolation factor is actually quite a big one. You go from a hospital team where there might be multiple house surgeons, multiple registrars, multiple consultants, not to mention the nursing staff and the multidisciplinary team that you're working with on a daily basis, to you're in a room by yourself with the patient. I mean, you might have other support people around you in the practice, but you lose a lot of that social aspect of work that you would have had in the hospital. The other sort of big thing that I found was the uncertainty that goes along with general practice, that when you're in hospital, when somebody leaves hospital, their discharge summary has a diagnosis on it. When somebody leaves a general practitioner's room, they seldom have a formal diagnosis. There may be a differential, there may be most likely what's going on, but you seldom have that sort of formal written, this is what it definitely was. And that uncertainty does take adjustment. It is something that I think a lot of people coming from the hospitals will have to make room for. To be honest, I'd say that for me the biggest issue would be around funding of general practice training. I'm meaning more actually the funding coming from the government and Health Workforce New Zealand towards general practice training. A GPEP 1 attracts a bit over sort of 20 grand of funding a year. You compare that to the average hospital specialty where it's 40 grand, and you ask yourself really how different is the requirement on the college, or the GP college versus the DHB, in terms of what they actually have to provide in terms of sort of educational services and that sort of thing for those trainees. I suspect that there's actually not as big a difference as sort of a twice the funding gap that you're getting with the GPEP 1s. And while the college has done a really good job in terms of lobbying to get more funded positions in GPEP 1, I think the next goal has to be lobbying to increase the actual funding in GPEP 1. The situation in the stage 2, the GPEP 2, is much worse. The funding for that is capped at 100 registrar places, which equates to a total of 470,000 a year. There are over 500 trainees in that area. So you're looking at actually, in reality, less than $1,000 per trainee in a stage 2 program. Compare that again to the 40,000 if they were a hospital trainee. Even if they were a second year house surgeon, that still attracts $18,000 worth of funding, compared to less than $1,000 for a stage 2 GP trainee. Now, the reality of what that actually means, it means that a lot of the costs of training for these stage 2 trainees are taken on by the trainees themselves. So the college charges a fee of $2,500 a year plus GST, and that's a reasonable fee in terms of covering costs of having visiting GPs come in to sit with you during the surgery. I mean, you've got to cover their lost earnings, that sort of stuff. I'm not by any means suggesting that the college fee is too much. I think 2,500 plus GST is, as I say, reasonable. But you've got that cost each year plus 2,100 plus GST for the fellowship visit. Plus, there's an academic component requirement in GP training, so you have to be doing sort of postgraduate study. Plus, if you want to attend any conferences, college conference, GPCME, these are also costs that the trainee has to take on. Whereas if they're a hospital-based trainee, DHB covers all of that. And it's quite a gap. You're talking at least, over a couple of year period, at least sort of upwards of 10 grand that is taken on by the trainee. And if you were to have anywhere near sort of parity, even sort of if you were to fund rather than 100 second stage registrars, but actually fund all of them, you'd be able to cover most of those costs. Now the reality is that to actually bring GPEP 1s and GPEP 2s in line with how much hospital registrars get funded, you're looking at a substantial amount of money. Doing the maths in my head, I'm thinking at least sort of 20 million or so, and that's just not going to happen. But to bring the level up to some extent, I think would be a good idea, not just for alleviating the burden of training costs on the trainees themselves, but also from the point of view of, imagine how much better the training program could be if the college were to receive that much more funding. And the other aspect would be, we've got a huge surge of GP trainees coming through. They need places to go to be trained. They need practices to go into. We've got talk of bringing in the PGY2 doctors in for GP placements as well. How is general practice going to fit all of these people, particularly when it's, you're talking about private businesses here? They need potentially going to need some assistance to actually increase their capacity to hold these people. And you do wonder whether if general practice were funded like any other training scheme, whether there might be more assistance available there. Well, actually, I think there needs to be some recognition that people don't move as an isolated unit by themselves. That in my own situation, the reason why I'm not in a rural area is how would my fiancée find work. There needs to be some way, and I don't have a sort of magic bullet for this, but there needs to be some way of actually supporting spouses and families when people do decide to make that change to move into a rural area. Because long term, I'd love to live in a rural area, but for my training with my spouse, where she is in her career, it's just not going to be possible. So I think that that's actually the area of work is more. It's not telling people that living in the countryside is nice. I think most people would like to live in the countryside if they were able to. It's more sort of actually putting the supports in place. Well, first things first, I say I hope that's not for long, because you'd be aware that the Doctors and Training Council elections, the nomination period is just closed, and I'm aware of 3 GPEP 2 trainees who are running for election, and also 1 rural hospital medicine trainee. And the reason why I'm aware is because I actually nominated them. So I'm hoping that that general practice trainees will get behind these other sort of colleagues, so that we can increase the representation of general practice on the Doctors and Training Council. In terms of the challenges of being the only one, and the reason why I want to increase the representation is that while we're very lucky in terms of the leadership that we've had with the NZMA, with Mark Peterson being a GP himself, but when you are sort of a sole voice, particularly, for example, at the trainee forum, at the forum last year, I was dually there representing the college, but also the Doctors and Training Council. And in the session where the various colleges got to go around and talk around what they thought the issues were, unfortunately, where I was sitting on the table meant that I was one of the last ones to go. And in a 90-minute session, I think it was, I got 2 minutes at the end. And I was talking to Tim Malloy, who was there as one of the speakers, about it afterwards, and he pointed out that actually, as a professional body that makes up 1/3 of all doctors in New Zealand, we should have closer to 1/3 of the representation, 1/3 of the speaking time, and that sort of stuff, which did sort of resonate with me, and it's why I was talking to other members of the trainee chapter executive, and we decided that we would nominate a few other people to try and increase their representation on the Doctors and Training Council, so that the voice of primary care is a dominant voice. Assuming that everything goes according to plan, I should be eligible to apply for fellowship from early December, so that's sort of the point where I hope to be doing a fellowship visit around that time. Assuming that all goes according to plan, actually the idea is next year, from probably around this time, my fiancée and myself, well, then she'll be my wife, as I was saying, getting married in 6 weeks, we plan to take sort of a year off, maybe more like 9 months, to just travel around the world, see some places that we haven't seen, basically catch up on the fact that because we've gone straight from university into full-time work, and then I've been doing the training program as well, that compared to a lot of our friends that have spent substantial chunks of the preceding few years doing travel, we haven't had that same opportunity yet. So we want to get that sort of out the way before we turn 30. For the time being, the focus is on getting fellowship and then trip overseas.